Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Open up, any standard anatomical atlas, and what you see is basically this pristine fantasy of color-coded perfection.
Yeah, the perfectly clean textbook pictures.
Right, exactly. You've got the blue veins, the red arteries, the little yellow nerves, and every single structure is just perfectly compartmentalized. But then you step into the operating room at like 2 a.m. for Hartmann's procedure. You're dealing with severe sepsis or maybe a perforated diverticulitis. And, well, that textbook fantasy is just violently thrown out the window.
You're completely gone.
Yeah. You are no longer looking at neat compartments. You're staring at this hostile, fused, inflammatory mass. So today, we are talking directly to you, the surgeons and medical doctors tuning in.
The ones actually in the trenches with this stuff.
Exactly. We are taking a comprehensive deep dive into the anatomical principles of Hartmann's procedure. We're going to really focus on the surgical techniques required to navigate this demanding, high-stakes environment where, honestly, the normal tissue planes have just essentially melted away.
Before we jump into dissecting the retroperitoneum and the deep pelvis, I do need to provide a really crucial caveat for everyone listening.
Sure, go for it.
This content is for reference only. You must always follow local guidelines and protocols in your own clinical practice.
Right. Absolutely mandatory to keep that in mind. So the overarching mission of a Hartmann's is pretty well known, right? You resect the diseased sigmoid colon and the upper rectum, you close the rectal stump, and then you bring out the proximal colon as an end colostomy in the left lower quadrant.
The textbook summary, yeah.
Right. But the actual geographic spread of that operation is massive. I mean, you're traversing the descending colon, the sigmoid mesocolon, the rectosigmoid junction, the deep pelvis, and then eventually you're re-engineering the abdominal wall itself.
It's a huge amount of territory.
It is. So to execute that safely, I think we have to start where the initial mechanical challenges pop up, which is dealing with the left colon and its messy mesocolic attachments.
Yeah, so in a healthy patient, the sigmoid colon is actually a relatively mobile structure. It's got a mesentery that, allows it a fair bit of freedom.
Right, it flops around a bit.
Exactly.
Yeah.
But the pathology that actually necessitates a Hartmann's, whether that's a locally advanced malignancy or, more commonly, a recurrent diverticular phlegmon that fundamentally alters the whole architecture.
It just wrecks it.
It really does. The sigmoid mesentery gets thickened, it gets shortened, and it becomes basically plastered to the retroperitoneum by these dense fibrotic adhesions.
Oh, wow.
Yeah, the body's inflammatory response is like actively trying to wall off the perforation or the tumor. So it turns this dynamic structure into just a rigid block of concrete.
I always think of pulling on a tethered, inflamed, descending colon like trying to stretch a short, frayed bungee cord.
That is a highly accurate way to describe it.
Right, because you're applying traction, but there's just zero give.
Yeah.
And if you rely on blunt force, something critical is going to snap.
Yeah.
So the immediate task is to take down those mesocolic attachments and somehow reestablish the white line of Tolt.
Which is easier said than done.
Exactly.
Yeah.
Because how do you safely find an avascular plane when the inflammation has completely obliterated all the normal visual cues that separate the mesocolon from the retroperitoneum?
Well, you really have to rely on tactile feedback. And, you need a deep understanding of embryonic tissue planes because the inflammation often creates this false plane that looks incredibly inviting.
Oh, like a trap.
Totally a trap. It leads you straight into the retroperitoneal vasculature. So the true avascular plane, Tolt's fascia, that requires meticulous, sharp dissection. You can't just go in there with blunt sweeping.
So no using a swab on a stick to just push it away.
No, absolutely not. You're looking for that specific areolar tissue that separates under gentle traction. If you find yourself hitting unexpected resistance, or worse, you get immediate small vessel bleeding, you've probably strayed out of the embryonic plane.
And right into the retroperitoneum proper.
Exactly.
Which brings up the physical goal of this whole initial mobilization phase. Like, in practice, I look at this and assume the ultimate make or break question is simply whether the colon will physically reach the abdominal wall without tension. Like, if you can't get it to reach, the operation just stalls right there, right?
I would actually push back on that slightly.
Oh, really?
Yeah. I mean, reaching the abdominal wall is secondary to the physiological state of the bowel once it actually gets there.
Oh, I see what you mean.
Right. Because if you aggressively mobilize the colon, and sure, it reaches the skin, but you've compromised the marginal artery of Drummond in the process.
Which happens if you pull too hard.
Exactly. Or maybe you take the IMA too high without verifying collateral flow. If you do that, you've just engineered a dead stoma.
Wow.
Yeah. So perfusion is always the primary goal. Tension-free reach is just the mechanical prerequisite to maintain that perfusion.
Perfusion over proximity. That's a great way to put it. And that kind of forces a total reevaluation of the vascular strategy because tension is basically the absolute enemy of hemodynamics.
100%.
When you pull a shortened colon up to the fascia, you're stretching those marginal vessels. And the venous outflow, since it's lower pressure, that gets compressed first, right?
That's right. The veins collapse before the arteries do.
So then the bowel becomes engorged, it gets congested, superadematous, and that swelling subsequently chokes off the higher pressure arterial inflow. And then, bam, you end up with an ischemic stoma that just retracts back into the peritoneal cavity a week later.
Which is a catastrophic complication. I mean, it essentially resets the patient right back to the severe sepsis they initially presented with.
That is a nightmare.
It really is. And to avoid that cascade, your dissection has to stay religiously in the correct fascial planes. Because straying outside not only risks bleeding that obscures your field,
Which is terrifying.
right, but it physically restricts the mobility of the bowel by tethering the exact mesentery you need for your exit strategy.
Which means we really need to talk about the hidden landmines buried in that retroperitoneal space. Because reaching the abdominal wall means you first have to bypass the structures lying directly beneath your dissection.
Yes. And there's a big one we need to talk about.
The left ureter.
The left ureter.
The literature across the board consistently highlights it as just the most critical structure to identify and protect during lateral mobilization and mesenteric division.
The vulnerability of the left ureter in a Hartmann's, I mean, it cannot be overstated. It courses right over the common iliac bifurcation in just terrifyingly close proximity to the base of the sigmoid mesocolon.
And normally you can see it, right?
Right. In a normal abdomen, you can often literally see peristalsis through the peritoneum. But in a diverticular mass, it is encased in fibrotic tissue, and it gets dragged anteriorly right into the surgical field the moment you apply medial traction to the colon.
So you apply traction thinking, you're just lifting the bowel, but you're actually tenting the ureter right into the line of fire.
Yeah, exactly.
There is this practical pearl from the sources that just demands attention here. As a rule of thumb, assume distorted anatomy until proven otherwise.
I completely agree with that rule.
I really want to emphasize the strict discipline this requires. Like, you shouldn't even think about dividing your vascular pedicles or firing a stapler across the mesentery until you have physically, unequivocally traced the ureter.
Visual identification is not enough.
Right. Not when severe inflammation makes a ureter look exactly like an engorged gonadal vessel or, a branch of the inferior mesenteric vein.
Exactly. You have to sweep the ureter down and away from the mesentery. Using a peanut sponge or just very gentle blunt dissection is mandatory there. You literally have to physically separate it from the overlying vascular pedicles.
And speaking of those pedicles, the management of the inferior mesenteric artery and its branches, so the left colic, the sigmoid arteries, the superior rectal, that's all central to this procedure.
Yes, and this is where the pathology really dictates your anatomy.
You're talking about the oncological versus benign debate.
Well, exactly. If you're operating for a malignancy, the goal is radical clearance.
Right, getting all the nodes.
Right. You need an adequate lymph node yield, which often dictates a very high ligation of the IMA, close to its origin at the aorta.
Okay, but a high ligation guarantees mesocolic lymphatic clearance, sure, but it immediately forces the descending colon to rely entirely on the middle colic artery, right, via the marginal artery and the arc of Riolan.
That's the trade-off. And if a patient has atherosclerotic disease at the superior mesenteric artery origin, or maybe an incomplete marginal artery at Griffith's point near the splenic flexure,
tying that IMA high will just instantly devascularize the descending colon.
Exactly. You achieve a perfect oncological specimen, but you sacrifice the blood supply needed for the stoma.
Wow. But conversely, if you're doing a Hartmann's for benign disease, like perforated diverticulitis, there's no oncological mandate to take the IMA at the aorta at all.
None whatsoever.
You can just preserve the left colic artery, ligate the sigmoid branches much closer to the bowel wall, and basically guarantee a much more robust arterial inflow to your future colostomy.
And the venous anatomy demands equal respect here too, specifically the inferior mesenteric vein.
The IMV.
Right. Because if you determine that the colon won't reach the abdominal wall tension-free, you have to mobilize the splenetic flexure.
Right, getting it loose up top.
Yes. which requires entering the lesser sac and dividing the gastrocolic ligament. And during this maneuver, the IMV is highly susceptible to traction injury. If you tear the IMV, or if you inadvertently avulse the splenic capsule because you're pulling down too hard on the colon,
the hemorrhage is just immediate and visually devastating.
this fills the field instantly.
And losing visibility in an already hostile, contaminated abdomen, I mean, that's the fastest way to cause collateral tissue trauma.
Panic sets in.
Exactly. You start packing, you start blindly clipping, and suddenly you've injured the pancreas or the stomach. But, okay, let's assume the blood supply is secured, the splenic flexure is fully mobilized, and the ureter is safely bypassed.
A good place to be.
Right. But then the physical space of the operation suddenly shifts. You basically descend from the relatively expansive peritoneal cavity into this much tighter, unyielding neighborhood, the deep pelvis.
And this transition at the rectosigmoid junction completely changes the mechanical dynamics of the whole surgery.
How so?
Well, in the abdomen, you have the luxury of lateral retraction. You can pull things side to side. But down in the pelvis, you are working within a rigid, bony funnel. The mesorectal envelope basically dictates your boundaries. The rectum sits anterior to the sacrum, separated by the presacral fascia, and directly beneath that fascia lies the presacral venous plexus.
The presacral veins, they're valveless, right? And they communicate directly with the internal iliac system.
Yes, which makes them incredibly dangerous.
Because if your dissection strays posterior to Waldeyer's fascia and you tear into that venous plexus, those veins don't just bleed normally. Because they lack valves and they're tethered to the periosteum, they retract directly into the sacral bone when they're torn.
Right into the bone.
You literally cannot clamp them. You cannot tie them off.
It is arguably one of the most difficult bleeding complications to manage in all of colorectal surgery.
I can imagine.
You're left trying to use mesofragments or thumbtacks.
Literal thumbtacks.
Yes, sterile ones. Or specialized hemostatic matrices, just trying to tamponade this high-volume bleed in an incredibly narrow space. Avoiding it requires staying strictly within the holy plane of total mesorectal excision.
Right, between the visceral fascia, the mesorectum, and the parietal presacral fascia.
Exactly.
But I also want to focus on the autonomic nerves that run through this exact same territory, because we are balancing the need to clear the diseased tissue with the imperative to preserve the patient's functional quality of life afterwards.
Absolutely. The superior hypogastric plexus and the hypergastric nerves run perilously close to your posterior and lateral dissection plane.
Right. And the superior hypogastric plexus sits just below the aortic bifurcation, right? And then it splits into the hypogastric nerves, which dive deep into the pelvis along the sidewalls.
That's the anatomy. And if you get overly aggressive with your lateral dissection, and this happens if you use excessive blunt force to tear an inflammatory mass out of the pelvis, you will avulse those nerves right out of the fascia.
And the consequence for the patient?
Devastating. Permanent urinary retention and severe sexual dysfunction.
Which highlights a really critical distinction we need to emphasize here. If you are resecting a low rectal cancer, obviously oncological radicality is the priority. You have to take the wide margin.
Yep, we take the margin.
But if you are performing a Hartmann's for a benign perforation, there is absolutely zero excuse to cause unnecessary deep pelvic trauma by forcing a dissection deeper than necessary. The pathology is typically at the rectosigmoid junction. You need careful, sharp dissection to separate the diseased segment. You don't just blindly rip tissue out. It's really the difference between meticulously using a scalpel to separate planes versus grabbing the mass and pulling it until something tears.
Yeah, but I will say, the temptation when you're staring down a rock-hard, bleeding, inflammatory mass at 3 in the morning...
Oh, I'm sure it's huge.
The temptation is to rely on blunt traction just to get it out and stabilize the patient, but that blunt force is exactly what destroys the pelvic autonomic nerves.
That makes a lot of sense.
And if we look anteriorly, the situation is equally precarious. You have the bladder, the seminal vesicles, or the uterus and annexa bordering this whole space. Denonvillier's fascia separates the rectum from the urogenital structures, but severe sepsis obliterates this boundary entirely.
It's just melts away. The inflamed sigmoid or upper rectum is often inextricably fused to the dome of the bladder. The purulent inflammation completely destroys the fat planes that usually provide a surgical margin.
Which is exactly why surgical judgment is paramount in the deep pelvis.
Right.
If the rectum is involved very low down, or if the pelvis is simply too hostile, edematous, and fibrotic to navigate without causing massive collateral organ injury, forcing your way down to healthy rectum is a profound risk.
So what do you do instead?
Recognizing when a dissection plane is unsafe and deciding to convert from a laparoscopic to an open approach, or maybe opting to perform a more conservative resection just to achieve source control that is a hallmark of surgical maturity.
Right, discretion in a hostile pelvis saves lives and organs.
Exactly.
Let's walk through the scenario where you have successfully navigated that gauntlet. You stayed anterior to the presacral veins, you preserved the hypogastric nerves, and you managed to free the diseased bowel.
Okay, best case scenario.
Right. You fire your stapler across the upper rectum. Now you have to deal with the rectal stump.
Well, firing the stapler in a narrow male pelvis is mechanically difficult to begin with. The angulation of the instrument often means you can't get a clean transverse lie.
Right. The angles are all wrong.
Yeah, and if you angle it poorly, you risk a spiral closure or leaving large dog ears on the stump.
And those dog ears are a problem.
A big problem. They are areas of localized ischemia and tension, making them highly prone to blowing out and leaking into the pelvis postoperatively. The stump must be closed without tension, without twisting, and it must have a pristine blood supply.
Okay, so once the stump is secure and the specimen is removed, the resection phase is complete. But the operation is far from over.
Not by a long shot.
A flawlessly executed pelvic dissection and resection is completely meaningless if the exit strategy, the stoma, is fundamentally flawed. You're transitioning from the deep pelvis to the superficial abdominal wall.
Creating the stoma site is an anatomical reconstruction in its own right, and honestly, it demands the same level of anatomical precision as the retroperitoneal dissection did.
Which is saying something.
Yes, the end colostomy must be matured through the left rectus abdominis muscle.
Not laterally.
No, routing the bowel through the rectus rather than bringing it out laterally through the oblique muscles leverages the rectus muscle to act as a sort of dynamic, supportive sphincter around the bowel. It significantly reduces the risk of a peristomal hernia.
I always compare creating that stoma to installing a doorway through a multi-layered security wall. To bring that bowel out, you have to engineer a really precise pathway.
That's a good analogy.
Thanks. I mean, you're incising the skin, navigating the subcutaneous fat, opening the anterior rectus sheath, splitting the fibers of the bulky rectus muscle itself, and finally opening the posterior sheath and peritoneum.
There's a lot of layers.
It is. And if you miscalculate the placement of that doorway, the structural integrity of the wall fails, and the bowel itself suffers.
Right, because the dimensions of that fascial trachea, the actual hole you're making in the fascia that dictates the survival of the stoma.
Wow, literally the survival.
Yes. If you make the trachea too narrow, you create a mechanical tourniquet. The fascial edge physically compresses the venous outflow of the colon.
And like we discussed earlier, the bowel wall becomes edematous. The swelling compounds the compression, the arterial inflow is choked off, and the mucosa just turns dusky and then eventually black.
Exactly. You have an ischemic stoma.
But the alternative is equally problematic. If you make the fascial defect too large just to avoid ischemia, you leave this gaping hole around the bowel.
Right.
And with every cough or movement the patient makes, intra-abdominal pressure pushes abdominal contents through that defect, inviting a massive peristomal hernia, or even a debilitating long-term prolapse of the bowel itself.
Yeah, so the surgeon basically has to thread the needle. It's typically a two-finger whip defect that allows the bowel to pass without constriction, but it provides enough support to prevent herniation.
And this really brings us full circle to the very first steps of the operation, doesn't it?
It absolutely does.
Because ensuring the colon can reach this precise fascial doorway without longitudinal tension and without twisting on its mesentery relies entirely on the quality of your initial retroperitoneal dissection.
Everything is connected.
If you fail to fully mobilize the line of Holt, or if you didn't release the splenic flexure adequately, the colon will be under tension when it reaches the skin. Every single discrete maneuver, from the left paracolic gutter down to the presacral space, it all culminates in the viability of this one piece of bowel hanging out of the abdomen.
Everything is fundamentally interconnected. The actions taken in the retroperitoneum literally dictate the hemodynamics at the skin level 2 hours later.
It's wild to think about it that way.
It really is.
So, to synthesize all these complex, geographically distinct steps into a cohesive mental model for the listener, we can actually distill this entire multi-layered surgery down to 5 pivotal operative questions.
I love this checklist. It forces the surgeon to actively verify their spatial awareness at every single phase of the procedure.
Right, so let's run through them. Question 1, where is the left ureter?
Have I physically swept it out of the mesentery before applying any clamps?
Question 2, where are the vessels?
Am I prioritizing a high IMA ligation for cancer, or am I preserving the left colic artery to ensure robust perfusion for a benign case?
Question 3.
Yeah.
Where is the correct retroperitoneal plane?
Am I in the avascular embryonic plane of Tolt, or have I torn into the retroperitoneal fat and vasculature?
Question 4. How low is the rectal stump?
Have I navigated the presacral space without tearing the venous plexus, and can I staple this stump closed without tension or dog ears?
And finally, question 5. Will the colon reach the abdominal wall without tension?
Right. Have I achieved enough mobility to pull the bowel through the rectus muscle trephine without compromising the marginal artery?
When you look at this checklist, and really look at it, you realize a pretty profound truth about this procedure. Hartmann's isn't just a simple bowel resection. It is essentially 4 distinct subspecialty operations rolled into one.
Yeah, it really is.
You've got a retroperitoneal dissection, a major vascular ligation, a deep pelvic clearance, and an abdominal wall reconstruction, all just stacked into one continuous high-stakes timeline.
That is the precise reality of the operation. True mastery doesn't come from merely knowing how to fire a linear stapler.
No, definitely not.
It comes from the ability to visualize the interplay of all these distinct anatomical zones simultaneously. You have to anticipate how a decision made at the root of the inferior mesenteric artery will ultimately dictate the survival of the stoma mucosa at the end of the case.
It's a continuous exercise in anatomical foresight.
Precisely.
Which makes this entire deep dive basically an exercise in respecting the anatomy before you even think about cutting tissue. The sources we've analyzed make one thing abundantly clear. A difficult, inflammatory case will violently punish any deviation from the correct tissue planes.
It really leaves you with a compelling thought to mull over, you know?
What's that?
Well, we call a Hartmann's procedure routine in the context of emergency general surgery. But given the sheer density of critical anatomy involved, the ureters, the autonomic nerves, the major vascular pedicles, the presacral veins, it begs the question, what other so-called routine procedures on your surgical roster might secretly hide a similar multidisciplinary anatomical gauntlet, just waiting for inflammation to obscure the map?
Oh, wow. That is a phenomenal question to end on. It really forces you to look at every single procedure on the board with a renewed sense of respect for the hidden complexity beneath the surface.
Exactly.
Well, before we sign off, I do need to remind everyone, if you like this content, then do not forget to share it with at least one of your colleagues or friends and spread the word. Also, check out our YouTube and other social media pages, and do check our previous season and episodes with some very relevant topics.
This has been a thoroughly engaging exploration of surgical anatomy today.
Absolutely. The next time you look at one of those perfectly color-coded textbook illustrations, just remember the messy, fused, incredibly complex reality that actually exists behind those pristine lines when the body is under siege. Until next time, keep digging deep.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.